All right. Hello, hello, and welcome to Talking All Things Cardio Pulm. I am your host, Dr. Rachele Burriesci, and we are here again with Dr. Aaron Thrush, back to talk about his hot off the press article. Aaron, welcome back, and thank you so much for coming on again.
Thank you, Rachel. Thanks for having me a second time. I'm excited to be here.
Of course. So this is like fresh research, literally off the press. Is it fully in print yet, or is this only online at this point?
I know it's online. I don't really know if it's in print yet.
Okay, sometimes one comes out first. I'm always
Yeah.
curious. So I'm just
Yeah.
going to read the title here: Development and Application of a Novel Framework for Mobility and Rehabilitation under Support of Extracorporeal Life Support, the MUSECLS Framework. So we're going to do a bird's eye view, but before we even get started, how do we want to call the framework? Are we calling it by an acronym? Are we saying out the letters?
Muscles.
Okay, so that's what my brain has been doing this whole time. And I didn't know if it was just that trick where if you're reading English, if the words are, the letters are incorrect. Okay, the
Yeah.
muscles
Yeah.
framework.
Yeah. So some people have tried to correct the spelling, and I said, no, it is an acronym, but then we can say muscles.
I
So that's
love
supposed
it. I'm so happy it's muscles because I'm like, would we say muscles? I was getting a little nervous of the pronunciation of it. Okay, so we're talking about the muscles framework. Give me
Yeah.
a little bit of a just a bird's eye view of what this framework is meant to do, its purpose.
So it's meant to give guidance on how a group of people, physical therapists and other rehab professionals and ICU teams can develop and then sustain a mobility program and a rehabilitation program for their patients that are on any kind of ECLS. We have a very good recent clinical practice guideline that really gives us the bedside best practice, but what we wanted was more of a program systems point of view to make this happen because that's really necessary.
Absolutely. And I think sometimes that's the biggest barrier to actually get started, where we have this great idea to really increase early mobility in a number of different populations, but then we hit a wall. And that wall can be ability to incorporate a framework like this, or even the relationships involved and also the teamwork that is involved. So I guess just right out the gate, let's talk about what this team looks like and who's involved in what we need to be, who's interacting in this interdisciplinary world.
It's so many people in the ICU. I mean, our practice where I work, as well as I think what's reflected and suggested in the guidelines, as well as in our framework, is that the physical therapist is at the center, along with our nurses, our occupational therapists sometimes, the perfusionists, the ECMO specialists, and then the ECMO specialists can have a variety of backgrounds and as well as the physicians, the intensivists, and the ECMO kind of program coordinators. So whether everybody's doing it at the bedside or not, or just involved in building that program, I think it depends. But those are kind of the core people in establishing the program.
Absolutely. Okay, so that's a pretty big team. That's a lot of coordination. It's a lot
Yeah,
of relationship building.
yeah.
Starting from beginning, we want to start an ECMO mobility program. These are the team members we need to kind of have in mind. How do we even start and initiate this type of activity in the ICU?
Well, my experience and the way this all developed was actually through COVID. And I think that that was the case probably for many
Yeah.
people. But it's certainly a unique environment in which all of this developed. So my personal experience was it was developing very quickly out of pure necessity.
Hmm.
The management of patients with COVID, from a variety of perspectives, was new, right?
Yep.
And so we were trying to just piece together best practice
Yeah.
related to critical care, related to what we knew about COVID. So it was a very reactive approach. And I think, again, in reflection after COVID and as this began to develop, we realized we developed it all very reflexively. And at
Yeah.
some point, we began to move out of the reflexive, um, approach and be a little bit more proactive and systematic and think about what we had done and what the gaps still were.
Yeah.
Um, So that's how we did it. And I think we realized that ideally, maybe that would not be the case. So now that we're in a post-COVID world and ECMO programs are still being developed, um, this was our attempt at saying, how can you do this a little bit more thoughtfully?
Yeah.
That those who did it as a reaction to COVID.
Yeah, a little more strategic in its efforts. What I would
Yeah.
say in reading it is it felt very organic in how it was built. Like you can almost feel that this was built in real time. But even though you said it was reflexive, there is a lot of reflection in it as well. And I think that we're going to come back to something we talked about last time. Culture, I think, probably played a big part of this as well. So we'll get into culture in a second. But I do think COVID was a catalyst for a number of different things in the ICU setting, including holds for, mobility or thinking outside the box and things like that. So just kind of knowing that we're in a different mindset at the start of this, right? This is COVID, we're in a pandemic, we're kind of figuring things out as we go. Um, but now we're kind of post-pandemic, so to speak, and now we're talking about sustaining and reflection. So we
Mhm.
have two different pictures here, right? One that's we got to make this happen, and one that's like we want to make this happen. Do you feel like the framework was built in a way that can now be a guide for someone who's saying, "Hey, I want to start this program, and what do I need to consider?"
Yeah, I think so, and I hope so. I hope that the framework might bring new things to mind that maybe somebody who's starting that program or trying to start the program may not have thought of, right?
Yeah.
I mean, there's elements of the framework that, start with the patient and the family, decision making around the patient and the family. We have things around equipment, things around how people view their roles and their scopes in different disciplines and how things, in our opinion and where we are, kind of people's roles and scope expand a little bit more, beyond what you traditionally think of in a variety of maybe allied health and nursing professions. And then getting at the bigger picture things around policies and competencies and trainings and continuous quality improvement and evidence-based practice.
Yeah.
So I hope that it helps. You can't do all of this at once, obviously. You can't even do it maybe in 6 months or 1 year, but at least maybe it's a bit of a roadmap to say, okay, while we may, what parts can we start with and
Yeah.
what parts do we need to have as a long-term goal for 6 months or 12 months or 18 months to know that as we progress, we are addressing all the things that might make this more sustainable in the long run.
Yeah, absolutely. Do you want to talk about that relationship building and culture first, or do you want to start with the patient center role first?
Um,
How would you want to lead this?
Maybe let's start with the patients.
Okay. I actually really like the fact that this framework had patient and family at the front. Like,
Mhm.
first thing we need to consider. Um, I guess first let's talk about why. Why was that a focus here? We hear
Yeah.
patient-centered care all the time, but I really felt it to be an important piece to not only the
Mhm.
framework, but also the care of the patient in mobilizing during an ECMO intervention.
Yeah, I think as the framework started to take shape in my mind, um, sometime very close to those initial thoughts is where I realized like the patient and the family should be at the center. And I think it makes sense from a variety of points of view. Our profession, as well as every other healthcare profession, right? What our purpose is really to be there for patients and to do our best care for patients, right? For patients and families. So from our professional point of view, they are the center of what we do.
Absolutely.
Um, Again, this framework is, we can talk about this more later, but it's a combination of what we do where I am and what we developed, as well as what we know from best practice.
Yeah.
It's not exactly what I do and what my team does here. It's the best of both kind of brought together. So
Okay.
so from the professional point of view, as well as from my home institution, um, the patient and family experience is very, very highly regarded. We have a lot of resources put into understanding and improving the experience of the patient. So it also made sense from reflecting our home institution and
Mhm.
how important the patient is, and them being at the center. Um, and then I think as well, just ECMO specifically, right?
Yeah.
Every case is different. The prognosis, the medical condition, the care plan, they're very individualized. So I think it also made sense, because this is specifically for ECMO, that all those unique characteristics and the challenges that come along with rehabilitation also just reminded me that, again, the patient needs to be at the center. How you motivate patients and how you engage with patients and how you build the team around a patient. Again, I think it just all comes back to the patient. So it's a really helpful and maybe grounding way to create that framework.
Yeah, it also sounds like buy-in is super important, where we're asking for patient consent and sort of creating a personalized feel to that session. How does that specific aspect work in the world of ECMO, in the world of the ICU, where we're coming out of sedation and really trying to have our patients awake who have multiple, at their most vulnerable state with multiple mechanical circulatory support type devices and medication? How are we really including the patient versus saying, we got to do this and just going for it?
It's incredibly difficult. I don't know that it's much different than the rest of critical care because this is a part of our everyday practice, but it is finding that balance between conveying to a patient and family how important and why we're trying to achieve what we are, and at the same time listening to them, incorporating what they feel they need and want. So of course things that help along the way are setting goals together, updating a patient on your professional assessment of how progress towards those goals are happening, um, providing things that might motivate them, the way that we communicate with patients. And we talked on our last
Hmm.
episode how actually that's challenging here because there's a lot of language barriers and some
Yeah.
cultural differences as well. Um, so it's very difficult. One interesting thing that came about from the framework is that in the later stages, we did go back to get feedback from patients and family members. And the one consistent thread from that feedback on our framework was, please listen to us as patients.
Yeah.
Please try to understand how we feel from day to day and take our feelings into consideration.
Yeah.
Um, which was just interesting to hear how common that was among the people that we went back to ask.
I can imagine that, especially in the ICU setting. I mean, just in the hospital setting, right? You're so out of control of what's going on around you. And especially if you've had a prolonged hospital stay, you find that patients kind of hold on to things that they can control. And sometimes that might be something as simple as saying no when PT comes in, right? Where they can actually take control. There's a fine line between allowing the patient to kind of dictate and also doing what's best for the patient. With the language barrier, with the cultural differences, do you find that that becomes very tricky, or do you find that patients go along with what is medically appropriate?
No, it is very tricky because feelings about decision making are
Hmm.
sometimes different here. Who makes the decision? The patient, the family member, the
Yeah.
husband, the mother. It's more tricky. I think that this brings to mind the importance of the pre-mobility huddle and also, a day-to-day huddle before
Hmm.
every session, but also the bigger picture for the patient and what their management is from multiple people on the team. Because the patient will feel something, the family will feel something, you'll feel something as the therapist, and then you have all the other providers who are also around, who are rallying for the patient and want to see them get better. And there's so many perspectives. So making sure that you have frequent communication as well as that pre-mobility huddle every day can help build consensus at least because
Yeah.
the physical therapist sometimes I'm not sure what the best approach is,
Right.
and so at least it's a sounding board and it's a way that you can at least make sure it's a group decision kind of and a group approach with the
Hmm.
patient as well.
The pre-mobility huddle, does the patient and or family member join that, or is that specifically for the team?
It's both. I would say you should do both separately,
Okay.
right? Like
Yeah.
because of course some of those conversations are sensitive. You're going to be talking about risks,
Hmm.
um, the patient's medical status, which they should be aware of, but the way that you speak about it as a medical team
Right.
um, might not be appropriate for the patient. So I would say it's an outside the patient room kind of initial discussion to get on the same page or at least have a few options in mind, and then going to the patient to present the options or the goal and getting their input and their buy-in in that as well. But I think it has to happen separately in most cases.
Does timing even play a role in that? For instance, like let's say the patient's like, I need an hour. Is
Yeah,
there a lot of flexibility in that? Because this is quite a production when you
yeah,
do get the team together, right? So like are you pre-huddling super early to kind of set the day and having the patient, kind of help dictate that so they feel like they have some control? Because I can even see
yeah.
that being a little piece where they just get a little bit of say in the matter.
Yeah, it I think it happens at multiple stages throughout the day. Usually what we do is early in the day, like before 9 o'clock, after we've done our own therapy huddle and we kind of have an idea of what the day looks like, we will contact the main players, the nurse, who will usually actually our nurse kind of coordinates things centrally. So we'll communicate to the nurse what time we think is appropriate. The nurse will check with the patient. The nurse will check with the respiratory therapist, with the perfusionist, with the doctor, whoever we all know needs to be involved. And then we have a preliminary agreement. And then, of course, that time comes around and things
May or
can
may
get
not.
shifted. Yeah, it's of course very tough because, as you said, just getting those people all free at one time
Yeah.
is a challenge. But we've been able to overcome that in most cases because there's a very good kind of consensus among our stakeholders on how important it is. And
Yeah.
our perfusion are primarily the kind of the specialists who are with us when we're mobilizing, and they're just incredibly supportive. So they're really easy to work with.
Okay. We'll do one more thing about like the patient perspective. There's a big focus on the personalized environment, kind of the me board. Is this something that you do in your facility? And what does that look like?
We do. We could do it systematically a little bit better, I think. And also, I think we can do better at recognizing earlier that we need to do these things. It sometimes is what we do when we realize, oh, a patient's going to have a prolonged run on ECMO, or this is going to be a long rehab
Hmm.
process, or
Okay.
there's a lot of goals that we're going to have to overcome, and then we start to think long term and put some of these in place. But really we should be doing it more widespread,
Yeah.
for more patients and not just ECMO patients, but for any patients. So I would say we do it, but we can even improve our standards and how we do it.
Yeah. I mean, that's the case for, I think, a lot of places in general.
Yeah,
But I
yeah,
do, I do like that little piece of it, even just like the music aspect, being in the ICU, hearing the beeping constantly, all of that sensory input, I'm sure we know plays a huge role in the psyche and everything else. So even just having something that's familiar to that person, I can see making a difference.
yeah.
I lied. I have one more question about the patient
Mhm.
piece. Okay, so
Okay.
communication is already, a barrier. We have a language barrier. We're using translators, sometimes translating to family, family to patient. In many instances on ECMO, we might still be intubated or have a tracheostomy. So now we have another layer barrier for communication. Do we typically use like picture boards or writing, or what's your mode around that? Because that adds just one more notch in communication.
Yeah. Yeah, so we've used all those things. They are at our disposal. We have our speech therapists who are involved, and they're also standardizing when they get involved and how they get involved, both from a communication as well as kind of a swallowing perspective. Um, so we default to them, of course, and then we carry out and manage whatever they're recommending for us.
Okay. I was actually going to ask that later on, but do you do a lot of co-trading with speech? Because I could see this being very dual task oriented for PT and speech.
Yeah, I don't think we've done a lot lately. I advocate for myself and on my team to try to only do that if there's a very, very clear purpose that,
Yeah.
the two of you together are going to bring more value than separate. We have the benefit of having a good bit of support in terms of just staff in our ICU.
Yeah.
Um, so we don't have a common approach of doing co-treatments. Of
Yeah.
course, we have more. I think it's a little bit more common in our neuro cases, really,
Yeah.
and not.
That's fair.
Yeah.
I can also see splitting those sessions being more beneficial for the patient, even more interaction
Mhm.
throughout the day and stimulation in that sort of way. Um,
Exactly.
so that brings me back to culture. I think it was a good setup. We have to get a good number of people in the same room at the same time for one goal, and that goal is to help mobilize said patient.
Mhm.
Culture is a huge part of this. And I think culture is probably one of the biggest barriers to a lot of institutions in getting these types of programs started. At least from what I've seen, literally moving across the country. Where there's really good culture, it's usually easier to implement. When there's maybe a lack of certain culture, maybe difficult. So I think
Yeah.
there's a couple of pictures here, right? There's just PT culture in the
Yeah.
hospital. And then there's the interdisciplinary piece. So I
Mhm.
guess first question, we're talking about your institution. How do you feel PT plays a role in voicing concerns or having a seat at the table in these types of conversations?
That's an area where I feel really lucky, and I've worked here in a setting where our physicians have driven some of this as much as the physical therapists.
Yeah,
Um, Again, really starting with COVID,
yeah,
we were being pushed to be involved in these patients, to push these patients to, and we were learning alongside of our physicians. They weren't just handing it to us and letting us go, but helping us understand what was happening with patients and how we can manage. Um, and the interesting thing is, those are physicians who had joined us maybe a couple of years prior from all sorts of countries from around the
right,
world.
right.
But to our benefit, they were very similarly minded that rehabilitation was so important. So so through COVID, we had their support. They trust us. They highly regard what we're doing. Sometimes they believe in what we're doing. I think more than we believe in what we're doing. Um, and particularly for the ECMO population, we've had those stakeholders at a high level that were supportive and involved. So the framework, we have a lot of evidence, as you know, about culture in critical care rehab,
Yeah,
generally in ICUs, and how to advocate. What are all the components of that? And we could get into that if it's helpful. The framework, because we don't have specific evidence in ECMO populations, the framework really takes that evidence from general ICU care and
yeah,
applies it the same way
right.
to that patient, so that if you're struggling with that culture and those barriers in your ICU, right now we just need to apply what we know from critical care rehab in general. That's having your champions from different disciplines.
Yep.
Personally, I think sometime you've got to figure out if data is going to tell the story. And is it your own data? Is it data from the literature? Does data not matter and you need to have stories? Do
Yep.
stories matter, right? Does one good story get people on board? Obviously, education, communication tools, a safe environment, um, a continuous improvement process environments, learning from each other. All these things are part of culture.
Yeah. And I think storytelling is a good aspect of that as well. I think data can definitely push things, especially when you start talking about length of stay and improvement in cost can be one, avenue to go down. But storytelling is very important in lots of different aspects in business, and I think that can
Yeah,
really get some buy-in.
yeah.
I think you're in a very unique situation. You're in a very new hospital that modernized very quickly and very pro PT. I think the relationship building from, I've also moved across the country, and so I've seen different institutions and have seen really great culture, I've seen okay culture, have seen barriers with culture. I do think relationship building is such an important aspect of pushing forward, you know, early mobility, an ECMO
Mhm.
framework. And you mentioned it last time, you cannot work in a silo. So, what types of maybe advice in relationship building with different staff members can sort of lead to this, where we have this ultimate goal that's going to
Yeah.
help the patient move and moving
Mhm.
that forward?
Yeah. Um, I don't know what the most important thing is, but I think some of the things are simple, simple approaches of treating everybody around you with respect,
Yeah.
not assuming what's in their mind or what's going on with their patient management that day. We have to come to the table able to express what we know. Okay, I've done a chart review. I know this. I know what these things mean. My additional question or the thing I need from you is XYZ, right?
Hmm.
So you're not coming to the table empty-handed and being like, are we mobilizing today? Are we doing therapy? No.
Yeah.
This is what I know. Can you fill me in on the rest? And then let's make a decision. So because you have to convey your expertise
Yep.
in this situation, you need to, they can't see you as a blank slate, just somebody with no context who's going to come in and try some exercise. Um, so it's a lot of those conversations where you're building trust and building accountability as well. Um, Demonstrating success, I think is a big part of it. Demonstrating safety in what you're doing.
Hmm.
Maybe again coming back to the patient, and when you do have differences, reminding everybody involved that the patient's still at the center, and you're trying to do this for the patient. Um, yeah, so somehow it's not a fast or an easy process, and maybe you can, with one misstep, you can set yourself back big
Yeah.
time. But
Or the opposite.
or the opposite,
I'll try to have
yeah,
a positive viewpoint on
or,
that.
or or the opposite. I guess it's hard to see the positive ones. It's maybe more in your face when you see the negative
Yeah.
one. But
I
it's really impressive when you see it. I mean, I reflected a little while ago about how even before COVID, we had a couple patients on ECMO.
yeah.
And I remember one of the first ones I worked with, I believe, was 16 years old and needed a heart transplant. And then he had a stroke while he was on ECMO.
Mm.
And there was not much consensus on what we were meant to do with this patient. And I was trying to piece together various opinions and figure out what to do. And that's my legs.
Yeah,
The
gotta do
bedside
the good
nurse,
old wave.
yeah, the bedside nurse said, "No, I'm not comfortable with you doing anything in this room.
Yeah.
I'm against. I don't agree with it."
Yeah.
And I don't remember what we actually did that day, but years later, a year back from now, so this is a span of, let's say, 6 or 7 years, this same nurse was helping us mobilize a patient on ECMO and IABP,
Yeah.
who, again, like 18 years old and needed a heart transplant. And I didn't realize it till the end. And I was like, wait a minute,
This is the
that nurse
same
was
person.
the one.
Was there
And
ever that communication afterwards?
um, I think in a very indirect way. I actually need to follow up with him probably. He's got my hat from a race last weekend that we did, so
Okay.
it's a good opportunity to
To
revisit
have
that.
that conversation now.
Yeah,
Yeah,
yeah.
I mean, it's interesting. I've seen that with, that's a culture within a culture too, right? So you can be in an ICU and you can, let's say, have 10, let's say, we'll just say nursing staff, 10 nurses, six are, pro mobility for early mobility, let's go. And then four, maybe a little bit more cautious. And it depends on maybe who you're working with that day to, you know, where you're going to get. But I do think
Yeah.
something that you said earlier in looking at policies and procedures and evidence that exists, not if it doesn't exist for ECMO, looking at other ICU,
Mhm,
resources. And I
mhm.
I do think that building trust with the team starts way before we're even considering an ECMO, mobilization team. And I think you have to start small. And I
Yeah.
do think like the small relationship things, and I tell students this and I tell colleagues this, the little helps throughout the day, the boosting a patient, the assisting with maybe hygiene or linen change, all those
Yeah.
little pieces that sort of build a relationship matter.
Yeah.
I mean,
Yeah.
do you agree with that? I find that I tend to help with those things probably more than most because I know that that's going to make a difference later on.
Yeah. Yeah, for sure. I mean, that's money in the bank, as you say, right? And you can
But
withdraw
that's
that
a
later.
positive.
Yeah, I mean, I absolutely agree. It's also helpful to make sure that when possible, they know that you're helping, out of the goodness of your heart to help. Like this is not physical
This is
therapy.
not therapy. Yes, that's that.
I'm
Thank you
gonna
for
help,
making that.
right? Like, this is not why I'm here, but I'm happy to help you because I know that,
Yeah.
that you're also gonna help me and
Yeah.
we need that teamwork. So that's very true. And as you said, even prior to ECMO, right?
Yeah.
So I was here for 4 years before COVID and before ECMO program really took off. And
Right.
my colleagues, again, at that time, we were a different team of ICU physical therapists, but we were a very strong team. We had really well, established ourselves in the ICU before
Hmm.
COVID, before ECMO.
Yeah.
So when that all happened, we had those relationships, that trust, those foundational principles were all in place, and we could build on that. And that's certainly true. And even now in my institution, as we're really making strides on getting more people into the ICU and properly trained, it it may seem obvious, but like you need to start with critical care concepts of rehabilitation for a
Right.
physical therapist or an occupational therapist, and then build ECMO because ECMO basically wraps up all the stuff you need to.
It's synthesizing everything you know.
It's all of it, and then an extra layer.
Yeah.
So of course you don't start with ECMO, right? You
Right.
start with all the other groups of
Yeah,
patients.
I would agree. I think that trust building starts way earlier on. Um, what about rounds? And I think it's said somewhere in the framework, but are you part of daily ICU rounds? Because I found early on, I mean, I'm talking like 10 years ago, we didn't have a early mobility program at the residency I was at. And so when we started, I started by implementing PTs being a part of rounds. And I felt like that was a really great bridge to have our voice in the mix, even discussing when a patient was becoming appropriate or when we should consider a consult. So tell me how that part works in your institution or, as a part of the framework.
Yeah. So we don't do the daily rounds. We're not part of that as the physical therapists. Those rounds go on for hours as
Hmm.
they do it in a
Yeah.
lot of places. We don't have the bandwidth. I think right now what we would get out from it is not worth what we put into it from a
Fair.
time
Yeah.
point of view. Um, but it all depends, I think, on the local culture and the level of collaboration and how that happens. So I partly don't think we would gain that much out of it because there is such close collaboration throughout the day
Hmm.
with different members of the team. So we're getting the referrals, we're having those conversations about what the plan of care should look like, what the goals are, how we're going to achieve it. So in other cases you might find that you need to put the time in for the rounds. And I'm only speaking right now of our cardiovascular um, ICU. When it comes to our neuro ICUs, our medical, surgical, oncology ICUs, the strategy is a little bit different. Not that we attend medical rounds per se, but there are other elements of at least weekly check-ins
Yeah.
where it is rounds essentially, right? Or project specific or very task specific rounds do happen in terms of audits, in terms of conversations at the bedside that we're involved in. So it always, of course, the solution always just depends on what the need is. But long story short, no, we're not
Okay.
doing those.
Yeah, I mean, that's fair. And that's a good perspective too. The ICU that I was in was a very small ICU. So rounds wasn't, an entire day's worth of
Yeah,
recapping. But
yeah,
it sounds like you are having those conversations case by case in different aspects. So you're kind of
yeah,
still part of that. So when a consult comes in, because consultation's part of this, what happens after that? What are the assessment pieces that we're looking at?
I mean, it depends what the patient condition is. Again, our physicians are pretty proactive. So sometimes we're getting a consult a few days before we can really meaningfully do anything.
Yeah.
Um, I think they're quite optimistic sometimes. And they all, of course, it's better just to have the consult
Yeah.
there to do a
We're
screening
we're
and then,
starting to think about it.
yeah. And then day by day, see the progress and obviously that's better than getting it late. Um, I would say that although we're not joining the rounds, as I said, sometimes we're getting calls before we even finish our morning huddle as physical therapists in our own office.
Okay.
Um, and these are the ECMO physicians who are calling saying, we've got this patient, what's the plan for today, whether a new patient or an older patient. So they're, yeah, just to say that they're very proactive. Um, if they don't see us by a certain time in the morning, they're probably making calls
Okay.
as well.
Okay. How
So
many patients on a day-to-day do you typically have on ECMO at this point?
it's really variable. I remember our busiest. Well, COVID is a blur. I don't.
That's fair. It's
COVID is a
also
blur.
5 years later now. Can we believe that?
Yeah, yeah, yeah. And I think we had between 10 and 15 ECMO
Wow.
machines.
Okay. That's a quite a
And
bit.
yeah. And of course, it was just an entirely different world. We were trying to separate ourselves. We were trying to only send one patient to see the COVID patient. So I don't have a good perspective, um, but since COVID,
Hmm.
there was a time where we had 4 patients who were actively mobilizing every single day on ECMO.
Wow.
That's the we've ever had. Then we go through some periods where we don't have any patient on ECMO that we're working with for rehab. Or more likely, we have 1 or 2, but they're not mobilizing. They may be more passive. Their medical condition may be worse. They might have other contraindications in place. So, a helpful perspective, maybe for people who haven't been working in this setting, is probably the majority of ECMO patients are not quite ready or stable for mobility. This is a selected group of patients, and that's what you read in guidelines,
Right.
in papers. Um, of course, we're always trying to remove all the barriers there are to patients being awake, moving, exercising, and mobilizing. But the reality is these are the sickest of the sick patients, and many
Correct.
of them participate. So this, people shouldn't think that everybody on ECMO is going to be going through rehab and mobility. Um, but that said, yes, from week to week, our involvement in ECMO patients is really variable. Sometimes it's very quiet, sometimes it's very busy.
Yeah. I think that's a good perspective that not everyone on ECMO is ready to go. Um, I think that I feel like in the last year, and I really have the fall conference still kind of like right here, there
Mm,
was a major, let's say 60%, 50%. It was a good amount of lectures specific to ECMO and mobilizing with ECMO. And I feel like it's kind of a hot topic right now, even though it's been around for over 10 years and really has taken off since COVID. I feel like it feels like things are moving right now. And I
yeah,
think it is a really good perspective for people who are just starting out to know that everyone on ECMO is not going to be ambulating. There is quite a range. So let's
yeah,
start talking about when someone starts to initiate mobility. There is a specific framework within the framework specific to
mm,
mobilizing, right? And it really starts with awake and alert to maybe verticalization to passive and
mm,
active activity to standing pre-gait, so on and so forth,
yeah.
that progressive mobility perspective. So give me some insight as to when we're really, you get that referral in.
Mhm,
What are our next steps? When are we starting to really engage with the patient? What type of
mhm.
passive activity are we doing to help determine if active work is going to actually happen?
Yeah. So I think, I mean, I would refer people first to the ELSO guideline that was published, I believe, in January of this year,
Yeah.
2025, because that's really the best concise summary of evidence. Our framework references that
Okay. Yep.
and talks about these kind of systematic screenings that need to be there, but we haven't. we haven't suggested adding or changing anything, from the guidelines, because
from
again,
that.
the guidelines are about that bedside assessment and
Yeah.
progression, and the framework is bigger programmatic things. So I think they actually complement each other very well.
Yeah.
But it comes down to a systems review, just like any ICU patient. You're looking at the neuro. Are they awake, following commands? What's the RAS? What's the GCS? What's
Yep.
the target? What are they now? Um, you are looking hemodynamically at the pressors that they're on, and whether those doses are stable or escalating or not, what the doses are, how many agents are there, if they're achieving the MAP goal that they need to be from a
Yep.
respiratory point of view, the settings on the ventilator. Again, there's well accepted standards, right? We talk about
Yeah.
FiO2 is 60% or less. We talk
Yeah.
about PEEP is maybe
Do you go by
12 or
less than? Yeah. Okay. So you're even higher.
yeah.
I feel like the
So,
standard used to
yeah,
be less than 10, and then COVID sort of pushed that as
yeah.
well.
And there's always, so we have a list of these in our institutions that we created that are our red flags.
Like
However,
your hard stop.
they're hard stops, but with in conversation with physicians and others, they
Yeah.
may, we may actually be assessing and working with a
There
patient.
would be a really good conversation if we're broaching those
Yeah,
red flag guys.
yeah,
Okay.
yeah, yeah. So again, COVID and ECMO are two, populations that really challenge what we used to have in place.
Yeah, it
If you,
definitely changed status quo.
yeah, I mean, we had patients who were saturating 78 to 86% at best at rest, and
Yeah. We're
this
like,
was weeks on weeks and months, and they're awake and able to function. So some of these things, of course, just have to be considered on the individual
yeah.
basis. So it's those systems checks.
Yeah.
Then ECMO just adds a few more things that you need to check. Obviously, knowing where the cannulation sites are, assessing them visually for their stability, whether they're addressed and secured the way that they need to be. Looking at the parameters on the vent or on the ECMO circuit, similar to a vent or similar to hemodynamic
Yeah.
agents.
hmm
It's what's the trend?
Yep.
Even if we're high support, is it stable and the patient's stable? Or have they been escalating? Are they weaning in a way?
Yeah.
All these things are just information that we're gathering. Of course, there's thoughts on femoral cannulation and whether that's stable.
Yeah. We'll
Any
talk
recent
about that. We'll talk about that one next because I was actually very surprised
okay.
by your numbers. But keep going on this because I want to try to keep it.
So again, I think just that the ECMO circuit and
Yeah,
cannulation site add a few more checks
for
that you need to
sure.
do. The rest of it is similar.
Yep.
Medically optimized so that they can be awake, following commands, and stable. And then it may be that you have to start with passive things, and in things in the bed. You might be mobilizing, at the edge of the bed, and you may be ambulating. Again, ambulating is like the holy grail.
I was gonna say that's like the big moment.
Yeah, yeah. But I will also say that um, the way that we design that mobility core, as it's called in the framework,
Yeah.
is this kind of upward trajectory.
Yeah.
Of course, you kind of move up and down this ramp according to daily abilities,
Yeah.
but we also have something in there saying that you don't focus just on mobility every day, right? Because what I saw sometimes is patients who are on extended runs on ECMO, and if you just mobilize day after day after day after day, there's actually all these impairments that are present that you need to start to address.
Yeah.
Because you can walk 100 meters, 200 meters, 300 meters every day. That's great. There's my lights again. Um, but especially for non-physical therapists, people will see patients walking and think they're amazing.
Yeah.
They don't have problems. Oh, they can walk. They're in wonderful physical condition. But actually, they have really severe range of motion limitations in the upper body, or chest movement, or balance impairments, or still strength, impairments. So sometimes we have to either give some level of mobility to others who can do that safely, so we can focus on things as physical therapists that's very much within our realm.
Yeah.
Or sometimes we don't mobilize one day because we need to focus on these other
Something else. I actually love that because I do
things.
sometimes think that we focus so much on walking that it becomes almost minimal in some ways, where there's so many other impairments that we need to address: chest wall mobility, diaphragm strength, sitting balance, you know,
Yeah,
trunk stability in general, strengthening,
yeah.
are very much underrated as an intervention that is
Mhm.
going to have effect for ambulation and endurance
Yeah,
and aerobic capacity in general. So I really do like that, distinguishing that it's not just going to walking, and that we
right.
can fluctuate back and forth, and day to day that might change, right? Just because someone was able to walk yesterday doesn't mean that they are going to be able to walk today, or maybe changing it up would actually give more benefit. um,
Definitely.
I really like that perspective because I fit very much in that, just in general treatment strategies and
Mhm.
interventions, like bring in other stuff as well. You talked about, in the framework, mobilizing or having mobility as maybe multiple times a day with different aspects. What does that look like? So if PT isn't, say, in this PT session, what would mobility maybe look like later in the day with somebody
Yeah, I mean,
else?
so it depends, of course, on what your staff outside of physical therapy, primarily nurses, what they're trained to do, what they're capable of doing. And then, of course, it depends on the patient as well, how stable they are and how they mobilize. So for all of our patients in our hospital, we have a very clear record of our recommendation each day on what the nurses can do for mobility in terms of transfers and ambulation.
Yeah.
We try to keep it simple, basic, but specific at the same time, and that includes our ECMO patients. Um, so I would say it's quite common here for patients who are on the upper end of mobilizing. Let's say they are ambulatory on ECMO. Um, the nurses will be moving the patients in and out of a chair. Um, we have a specific exercise program that's simple and using therabands that we give that can be done in the evenings, the weekends when we may not be there,
Mhm.
um, including having a patient stand up and just march for a while.
Yeah.
Um, so there's some patients who are mobilizing at the bedside multiple times a day without the physical therapist. We have had some very specific patients and circumstances where patients were mobilizing as in ambulating
Mhm.
outside of the room without the physical therapist there. Of course, we put extra precautions there in
Yeah.
terms of how it's happening, but that has been, we've been successful with that as well. And I think it's important to know, like, each program needs to figure out what they can do within the
Hmm.
realms of safety and what resources they have.
Yeah.
There's a good publication out there, at least one that's a very good publication that talks about a nursing-led mobility program, including
Hmm.
ambulation. Now, when you read it, you realize there are significant differences between what that looks like versus a physical therapy-led mobility session, as there should be.
Hmm.
But there's different ways to address this kind of care that the patient needs from multiple avenues.
Yeah.
So it's sitting with your stakeholders and figuring out what you can put on paper and making sure that those protections are there as well in terms of things being put on paper.
Yeah. That makes sense, especially the resources that are allotted throughout the day. And if
And I'll,
physical,
I'll mention,
yeah.
uh, sorry, just as well, that we do have a part in the nursing ECMO education that happens
Nice.
sometimes every 6 months or every 12 months. It really depends on how many, what the need is to train more ECMO nurses. But that, I think, week-long course that our hospital does,
Oh, nice.
we always get pulled in to do a session, and it's evolved over the years, so it's really good. Now we do a presentation, we summarize evidence, we show some of the data that we have from our hospital to give new nurses confidence
Yeah.
and seeing
Buy-in.
that they're safe, buy-in, and then we go through a simulation as well. So it's really good to be part of that and get that exposure to the nurses at the very beginning of their training.
Yeah, that training I think plays a huge role too. If you have even transfer training, ambulation training with the nursing staff where they can feel more confident in their abilities, plays a big role. Do you do like a train the trainer type thing, or is it always in this like every 6 month simulation type?
Yeah, we for the most part we just do this in their training sessions initially. We have done train the trainer on specific items for our use of the Motomed,
Hmm.
the ergometer. We've done train the trainer where we had two nursing champions who have gone around and trained others, and at the same time they actually did training on this resistance band and bedside exercise program as well. So
Nice.
there's a of skills and that was gone over. So we have used it in that
That's
way now.
fantastic. It just adds more reps throughout the day and checkpoints and things like that. How about from a PT perspective? How many PTs do you typically have trained in the ICU? What that competency might look like in just like a broad perspective, because I don't want to go too far outside the framework.
So to put into perspective first, I think we have about 15 or 16 physical therapists in our hospital inpatient team.
Yeah.
Uh, Four of us are fully trained for ECMO.
Okay.
Two more are currently undergoing training and haven't finished. And then two more worked with ECMO patients historically before we had our competency actually all mapped out. So, but then have moved on to other areas and not really been involved. So we could bring them back and kind of put them through the formal training
Yeah.
again. They have experience, but they're not doing it now. So I would say about six
6.
are, yeah, and
That's a
it's
good
a balance.
number.
Like it's a good number, and I don't think I would want to go much more than six because the more patient, the more therapists you have trained, the less exposure they have
Yeah.
when you have a limited number of patients.
That's
So,
a good point.
you need to make sure that they keep exposure year after year, otherwise the skills won't be there. So, yeah, so I think that number is probably ideal, and I wouldn't go
Go
more.
past that. I think that's
Yeah.
also important for relationship building with your team too, right?
Mhm.
If you have, say, 10 of your 16 PTs all kind of in and out of the ICU, do you really have that same relationship with your core team members, your RTs, your nurses, your perfusionists?
Exactly, yeah, and that's also a change that we've made in just how we staff our ICUs, as you've mentioned over the last year or so, having a more dedicated ICU team,
Hmm.
because I think it's invaluable to have people who are there all day, every day. They're seen, they're not a consult that's coming in and out
Yeah.
according to requests them. So that's really really important.
Yeah, I think it just builds a lot of trust across the team
Mm,
members when you have that familiar face, you have that person who's consistently in there having positive, outcomes versus just like this random person shows up and you're like, "Hey, I'm the PT here today." And you're like, "Oh, how, you have that question mark of how is this going to go?" I think in
yeah,
this situation, this population, there should be no question marks.
yeah, for sure.
Um, Before we move on from like team members, the only two people we really haven't talked about were the RTs and the perfusionist. How much of a role or what type of role do they play during ambulation, and how important are those relationships as well?
Yeah. They're very important. They're critical. Our way of practicing and our policy or procedure as we've written and published it is that of course if somebody's on a ventilator or you have a specific respiratory need, we would have the respiratory therapist involved to handle that.
Yeah.
Um, if we're mobilizing away from the bedside, so if we're doing more than marching and transferring to a chair, if we're ambulating, we need either the ICU physician or a perfusionist with us. That's our policy.
Okay.
Um, I would say 95% of the time it is the perfusionist.
Okay.
Um, they're available, extremely collaborative, flexible, amazing resources for us. Now, depending on your program, you may have ECMO specialists with a variety of background. They would step in and do that in the same way, I would imagine. But we're using our
Okay.
perfusionists. So, so those are the expectations that we have. And again, the framework doesn't advocate for that or anything else specifically. Again, it does reference that the ELSO guidelines the ELSO guidelines actually really nicely describe what the recommended role for each person is.
Nice. Yeah.
And then, of course, when you look at literature that's published in the last 1 or 2 or 3 years, even, there's multiple models given, and the track record in terms of safety is good using multiple methods. So again, I think it's a local discussion about your resources and how you're going to work and what your mutual understandings are, and
Yeah.
there's multiple on how you can do that. And usually when I present this framework, and also reference the guidelines, I just say it is helpful. Although you start with the guidelines, check what these other publications in the last few years are saying, because they will give you a sense of the variety of ways that you can do things. It'll give you options. Maybe your population is more specific to this publication or this publication.
Yeah.
That gets reflected in what the standards are. So it's important to look beyond the guidelines to get some examples that can really help you map out what you need.
The checklist of each person. I think that's a good perspective as well. Let's talk a little bit about cannulation. And I was very surprised. First of all, this is a great N. We have 802 physical therapy sessions.
Yep.
Of those 802, I'm just going to give some stats and numbers first. 241 were ambulatory, so that's a 30% ambulation rate. 289 active bedside mobility, so that's 36%. 273 were bed-based active or passive exercise, which is 34%. Of those 802 sessions, we had a very small number of events. One major event, which included profound desaturation and loss of consciousness, and then 22 minor events, which range from hypotension, maybe some adjustments to, actually, there was only one that required adjustments to flow, if I remember correctly, but regardless, minor events nonetheless. What I found, 9%, I'm sorry, there's a number, only 9% required modifications to ECMO settings. What I was very, very surprised with was that 85.8% of your patients have femoral access. So this has, I feel like, in the world of ECMO over the last, say, 10 years or so, has been like the conversation, right? Where should we have cannulation location? Are we mobilizing only patients with IJ? I feel like Chicago, the University of Chicago, was one of the first people mobilizing with femoral access years back already. And it kind of is do you, don't you, right? Usually when you hear femoral access, we hear bed rest after that. So, I mean, there's a world of difference, right? We have femoral access, immediate bed rest, and then we have ambulatory.
Yeah.
That's a big range. And I still see it here in the States, right? Like that range still exists. So let's talk about a little bit of the how. I know this isn't the huge part of the framework, so again, we won't go too far out of it. And also, it seems to be very successful and safe.
Yep. Yes. So in doing the literature review that contributed to the framework, I can't recall anything, nor did we include anything in the paper that suggested that femoral cannulation should be seen as a less desired cannulation site. In theory, yes, we understand that the hip is flexing a good amount and the location may be challenging. The 88% or something that you referenced for us is absolutely true. Our preferred cannulation strategy is femoral jugular. And we have had little to no issue at all. The only major event, as you mentioned, was with a patient with a dual lumen jugular access. And somewhere around that time is when we started seeing a lot less of them and a lot more femoral jugular. And I remember at some point asking a physician, and they're like, "This is what we're doing now." And actually, it was our physicians who were we again in the COVID era. I remember that our perspective coming to the conversation was, "Oh, this is great. They have a jugular only access." And our physicians were actually saying, this is harder for us to manage in mobility than if we do ephemeral. And they went through the anatomy and how it's done and the stability and how it's stabilized and all these things. And we had to see it, I think, to believe that
Yeah.
actually it was way easier with ephemeral and a jugular access than a single site dual lumen.
It
Now,
also makes sense just from size and location of the vessels.
yes, yeah. Yeah. So now when you read, for example, the ELSO
Hmm.
guideline in January, it does reference that although there are papers and publications that advocate that a single site dual lumen may facilitate mobility, that they're actually probably more prone to dislodgement or let's say malpositioning at least, which
Interesting.
is exactly what happened in our major event. It was a very temporary kind of loss of consciousness into saturation. The physician was there immediately and just did a small maneuver, recognizing probably what happened. Just there needed to be a rotation of the
Interesting.
cannula. The patient was fine and actually continued to complete the
Good to go.
yeah, good to go. So, so otherwise, again, going back to the ELSO guidelines, if there's a femoral line in place, they recommend that it's just an extra step in the screening process. When the patient's in bed, flex the hip to 90 degrees over and over, watch, reassess the cannulation site for any
Yeah.
sign of dislodgement, watch the flows on ECMO, and there's something else in there. Maybe the dressing, the
Any
location, the
like
femoral line.
hematoma, bleeding from the site? Like, is there
Oh,
any
perfusion, distal perfusion. Yes. Yeah.
perfusion? Yeah, pulses.
Yeah.
Okay, so I've
And
read
then,
in
yeah.
preparing for this, I was reading this hip flexion to 90, and I'm like, okay, I need more. Now I gotta like really dig into this again because this is not my
Yeah.
primary population here.
Yeah.
Um, so we have femoral access, and our check before mobilizing is to flex the hip to 90.
Mhm.
And
Yes.
that is safe.
Yeah.
And we
I
haven't
mean,
had, I mean, no events occurred with this. It would be documented as well.
yeah, for sure.
And I
Yeah.
have heard that physicians prefer femoral access, and
Mhm.
I always thought this was a limitation to potentially mobilizing until verticalization beds became, much more
Yeah.
popular. And I'm like, okay, this is great. Now we can just stand and get off and then we're good. So
Yeah.
are we, now that I'm like, processing all this, we're just hip flexing to 90. Any concern with then
Yeah.
sitting edge of bed?
Nothing. I mean, concern. Yeah, we should be concerned.
Well,
I mean, we should be vigilant, right?
let
However,
me
we
change
have
my words.
we have never um, had. Now, of course, my colleagues are out doing this as well, but like
Yeah,
of those 800 sessions, I think I did 400. Like we have never experienced the problem.
interesting.
In fact, our patients with femoral access routinely, as in like every day, are sitting in a chair upright. If they're not at 90 degrees, they're maybe at 100 degrees of did I say that right?
I think so.
They're sitting upright for hours.
Yeah,
No, no issue. So again, it's something to monitor for
yeah.
sure, but we had any issues? No. And those, I would, the physicians in my mind were completely right. I am so much more at ease with a
With the
femoral
femoral.
line. They
Interesting.
are plastered along the front of the leg,
Yeah.
not going anywhere. They are long. They are
I feel like
not
the
going to rotate.
suturing is different too, like more stable internally.
I don't know specifically about that, but even the external, when you have a jugular, all it is coming from here. There's a dressing
Yeah.
going over here. You're using a
Headband.
strap to
Yeah.
put it in place. But any movement is rotation, and that's
Mm,
affecting the flow of blood and where it's supposed to hit.
including
So
shoulder flexion, I would then presume.
yeah, I mean shoulder. We haven't had issues either, but it's definitely something we have to watch for, especially depending where that dressing is, as well as often on the contralateral side. It's coming down, and they'll use one of those anchors on the upper and
Mm,
lower chest or abdomen, which sometimes actually is the dressing itself is affecting range of motion. So that's again just the importance of an early screening and assessment by a physical therapist can even be to realize like, oh, you guys
This is
have like
placement.
just
Just,
arm.
yeah, we're just locked it out
So
now.
yeah, so you can kind of give your input on multiple things that might be, impactful down the line. Yeah.
Okay. Well, I thought that was one of the, I mean, just really stuck out to me. I was
Yeah.
expecting definitely more upper IJ type, so
No,
femoral.
not
Yeah, I loved it. I mean, I
it
think
works.
that
Yeah.
I think that also helps other institutions that are maybe limiting mobility because of femoral
Mm,
access to say we have
yeah.
multiple studies, multiple, publications
Yeah.
stating safety with this. I mean,
Yeah.
typically when you're reading a lot of the ECMO information, it's concerns for kinking of the line, dislodgement of the line. Like those are, in my opinion, catastrophic
Mm,
type events.
yeah.
And with mobility, flexing that hip to 90, we're not kinking, no real concern for dislodgement. Love it. I love it. I think this opens a lot of doors for people because I have heard in recent, you know,
Yeah.
conversations that femoral access is preferred method for physicians, and therefore mobilization is becoming, is limited from getting to edge of bed because you can't hip flex.
Yeah.
Then comes
No,
the talk of
there's
verticalization beds. So you're not even, are you
yeah,
typically using verticalization beds to start your ambulation or no?
we never have.
Interesting.
We should in the near future, but that's never
Awesome.
come.
But
The
from a safety perspective, it has not limited you.
No, well, it hasn't limited us for ECMO patients. It very much limited us for IABP
Mm,
femorally placed
okay.
patients. So I'm absolutely there's a role for those beds. We would use it again, not specifically because of femoral ECMO, but because of femoral IABP or
IABP.
similar devices. So that's the opportunity for us here, which
Yeah,
we need to pursue. Um, and we have a tilt table that fully verticalizes as well, and we're actually working on the protocol and just ironing that out before we will use it in the same way as a bed. But yes, and there is data certainly out there,
yeah,
which you can find reference in our paper as well as also guidelines that talks about the safety of femoral lines. So I'm also a little bit baffled when I hear people talking about how that's like a hard stop in their
yeah,
facility. I don't know why that has to be the case. Hopefully it is changing practice because again, I don't want to advocate for one way over another. We
for
found a way
sure.
that works very well
Yeah,
for us, where the important thing is you're on the same page as a team.
yeah,
You have a system in place to track your safety events, and you periodically look back at that and see if any adjustments need to be made. And if
yeah,
you can safely mobilize with upper body cannulation, which many places are doing, then
yep,
that's fantastic.
right.
Um, it's just one of those things that the team it's better to have a preferred method and then to have each patient along the way present differently for the rehab team,
Yeah, that's fair. I think that's an important piece too for the actual treating physician, treating physical therapist to consider as well. If you have different, constant change in your location, that's going to be a different technique each time, or, you have to adjust to it. Okay. I think I know that's not really where the framework was meant to take us, but I wanted to at least hit it because I think it's I think you have really good numbers showing that safety and also giving another layer of, hey, we did adjust to the event that occurred from upper body, and we found that the femoral has actually been maybe more stable, more safe.
yeah, and we hopefully we'll have a publication within the next year or so that's illustrating all that with our data. I have presented it in conferences, kind of in platform form, but we need to publish it because not only is it, as you said, almost 90% of our sessions are done with ephemeral location, but we statistically looked at the occurrence of either a minor or a major event
Hmm.
when there's ephemeral, even across different levels of mobility for in bed, rehab, for bedside mobility, and for ambulation. Are there any differences? And there's no difference in safety events across those different variables.
That's fantastic. Also, I was going to say, I am sure there are a number of different research potential within this 802 patient,
Yeah.
um, talk about the information that you kept on these patients, because that is part of developing a program like this, quality assurance, quality improvement type projects. What types of things did you retrospectively look at and then like are now looking at going forward?
So we have a registry that's referenced in the paper, and
Mhm.
some numbers are used to portray different ideas in the framework. Um, it's all retrospective. Of course, if you do anything prospectively, there's consents and things get very much more complicated. So we periodically review retrospectively
Okay.
every single physical therapy session on ECMO. So we have, no, it's been a while since I looked at this. We have things like how many minutes the session was.
Okay.
We have what their respiratory or ventilator support is, the mode, the PEEP, the pressure,
FiO2, yep.
whether they're on high flow or nasal cannula or whatever. We have whether they're on any pressors. We have if they're on CRRT at the same time.
Okay.
We have their ABGs in terms of whether it's normal, abnormal, or abnormal but compensated. Just those three buckets. We have their hemoglobin, hematocrit, lactate, um, and then of course you have any safety events, whether they're minor or major safety events, and whether they're patient-related factors or circuit-related factors.
Oh, that's good to distinguish.
Yep. And we have their cannulation site.
Yep.
Um, of course, if they're VV or VA, and then we have outcome. Oh, well, we have the FSS ICU in every session,
Okay.
and then we retrospectively assign an ICU mobility score.
Okay.
Not something we document in our daily notes, but we
Go
assign it
back to. Okay.
Excuse me. Um, and then we have our final patient outcomes. Like we have, okay, how many sessions did they complete? How many were deferred? How many per week does that come out to? What's their discharge destination, whether they survived or not? Um,
Do you have length of stay broken up into ICU and like long term?
we have ICU days and then hospital days.
Okay.
Yeah. We have how many days they were on ECMO prior to coming to our hospital because sometimes other hospitals will cannulate before sending them to us.
Okay.
Uh, yeah,
Days prior to initiation of PT?
yes, we have exactly how many days to get the referral, how many days till we screen them, how many
Mhm.
days do we actually complete the evaluation. Um, yeah,
Yeah, I mean it's great data and I think something that people who are building a program could think about
yeah.
retrospectively or prospectively. I do agree the consent part of that makes it a little bit more tricky.
No, it all just depends how you set it up. I mean,
Yeah.
if it's a quality improvement project, then obviously you don't have to do
Hmm.
that. But we wanted to set ours
Go
up
through
as
IRB.
essentially, yeah, for research.
Yeah.
So, and that's the other thing. This is all manual work. Of
Yep.
course, you would want to, if you can automate some of this, that would be amazing. And we probably need to look at that. It was done at a time when I had a partial allocation to research, so I could maintain this registry.
You could actually
Um,
manually assess and input.
yeah.
Yep.
Yeah, yeah. So it's not a resource that everybody will have, but of
Yeah.
course, the framework talks about figuring out like what are your KPIs. The
Yep.
also guideline also suggests like these are some metrics that every program should follow. So that's a good starting point, and then figuring out what other metrics you have, and then obviously specifically doing spot checks or whatever smaller scope quality improvement projects to know that you're following those KPIs. You don't have to look at all these things that we're looking at. This
Yeah.
is more research perspective.
Big picture research. And I'm sure you're going to be able to pull a lot more data from it as well.
Yep.
I did have more questions. I lost track of my timeline here. Um, try to keep us on the framework. All right, so we talked about oh, let's talk about audits. We talked about the information that you're keeping. Tell us, there's a couple of different talks about regular audits of mobility activity, of rehab interventions. I'm assuming some of the planning procedures. Talk a little bit about the audits, how frequently they occur, what we're looking at.
So, I mean, I would say we use those 802 visits as like one big audit so that we
Okay.
know what we've done.
Yeah.
And I use that information to illustrate to people, let's say, as they're going through the ECMO training, this is what we do, this is how we know it's safe, these are the patterns that we've seen.
Yep.
Um, so we use it for that perspective.
Okay.
We have then a meeting of our ECMO therapists once every 2 months, which is
Okay.
probably not as frequent as we, ideally would have, but we're pressed for time. So this is what we're doing at the moment. So that's an opportunity for us to, it could be review an audit, or it could be review anything. Sometimes it's like a case study that we had. Sometimes it's reviewing evidence, new evidence that we have,
Hmm.
reminding ourselves, just going back over all of our procedures that we have in place, reminding ourselves of all these things. So that's not audit per se, but kind of, part of our ongoing quality improvement
Okay.
process.
What types of debriefing are you doing day to day? And then I guess like I'm assuming that 2 month audit type meeting as well.
Yeah. So every session where mobility is done, um, we will debrief. So everybody that was involved in that mobility session, basically, once you return to the room, everyone's scurrying around to replace things, check things, get the patient comfortable. Um, when that's being wrapped up, the physical therapist will say, all right, guys, stick around for a few minutes. Let's all stop what we're doing and let's go around and each person, please, like, tell us what you think went well.
Yeah.
And if there's anything you think we need to do differently tomorrow or the next time, or anything else that you want to do. Um, and that's, yeah, just kind of like an open forum for people to communicate
What
what they
what went well, what didn't go well. If a
exactly.
event, a minor event, major event happened, I'm assuming that'll
Hmm.
be part of the debrief. Would that
Hmm.
then be documented in a more than just like in a checklist type thing, or how would that be addressed?
Um, I mean, we very clearly document in our physical therapy note if there
Hmm.
was any concern at all. Of obviously, like part
Yeah.
of standard practice, even vitals, if they're not out of the ordinary, we're monitoring it and
Right.
recording. So we, and also because we're aware that I'm collecting this data retrospectively, we have checks in place to make sure that these things get documented. So
Yeah.
even if something did not become an event, if it's a minor event, we make sure
Hmm.
that it's very clearly written in the notes.
Okay.
Um, and then of course there's the hospital's event reporting system, which should be used not only for events but also for near misses.
Yeah.
Um, I think everywhere there's variability in practice in what gets entered and how it gets entered. Clearly, I think the difficult thing, of course, in this population is everything is a risk. I
Yeah.
mean, like this
Yeah,
person's
for sure.
existence is a risk. Every day is a risk.
Yeah.
So every day there are potential harms to the patient as well. So how do you weigh which ones get put into
Yeah.
a registry for safety and which ones do not? I mean, our safety profile, according to the numbers that we have, is, I think, better than anything I've seen published.
Hmm. Yeah, your numbers are super low. I think the major event comes
Yeah.
out to 0.12%, and then the minor events comes out to 2.1%. And don't hold me to those.
Yeah.
I don't
Yeah.
have the numbers in front of me, but it's very
Yeah.
low.
I mean, one major event out of 802 sessions, right?
Yeah.
That's like, so if one session out of 800 is reported, I mean, it should be, I suppose. But what will you do with that information? If you compare it to what the risks are and
Yeah,
what standard is, you would applaud your efforts in providing safe care.
for sure.
Or something, this is unsafe, we're going to shut it down.
Shut her down.
So,
No, but I do think I mean, you mentioned it earlier. So you had these 802 sessions. You had this one major event, which result in transient loss of consciousness with an adjustment of the tubing, and then you literally carried on, right? It did sound like maybe with debriefing that something did change after that. For instance, maybe that's when we switched, you know what, I'm actually safer with femoral. We don't need to take that risk again. Do you feel
Yeah.
like that was kind of part of that debrief scenario?
It very well may have been. Now, based on my memory, I can't say
For
100%,
sure.
but
That's fair.
it would have been around the same time that
Yeah.
we started a shift in practice. So I can't say for sure, but we did evolve our practice in another direction. So I
Near
think
after
so.
that, potentially.
Yeah,
Okay. Yeah, that I
yeah.
mean that is a good I think I mean there's so much information out there on debriefing and the benefits of it and closed loop feedback of all of those things kind of help improve most projects. So the fact that it's also incorporated into this framework, I think really hits a number of different perspectives. I think this framework is just very comprehensive, looking at the different interdisciplinary teams within it. Like you even discuss dietitians' role in this and the importance of nutrition and what that might look like, speech's role in this, PT's role, potential OT role. So I think there's just a really nice development of what can be put in place for someone who is starting out. Like, let's look at the big picture, roadmap of this thing. I do believe that this is a really great roadmap for someone who is starting out. And again, like you said, overlapping with the ELSO guidelines. I'm going to go back to the picture because I want to make sure I didn't miss a big point of the muscles framework. I think we hit a good amount of the nitty gritty within. Policies, pathways, and competencies. We've kind of hit on that. Maybe talk a little bit about the development of, say, a specific policy from inception of this. Policies sort of require like that ladder approach in administration work. How do you feel like those policies have developed? Is it within the PT department, within the nursing department, and then there's overlap, or was it all of the players, all the stakeholders together creating that
Yeah.
policy or procedure?
So we have a few policies or procedures, or some are policies and some are procedures within our critical care rehab practice. The ECMO mobility one is a procedure, and that was put together by two of us as physical therapists,
Okay.
with input from from a slightly wider PT team and physicians reviewing it, and then of course a standard procedure of how that goes through the Quality and Patient Safety Institute to become a procedure. So there's obviously checks in there, but it was the physical therapist who created that.
Okay.
Um, as well as all the other rehab policies that we have. We have one for mobilizing with an ET tube or tracheostomy.
Yeah.
Um, we have one in production now for verticalization on a tilt
Nice.
table and ambulation. So we're very much the owners of that, and then we take it through the process that the Quality and Patient Safety Institute have.
Okay.
Um, so yeah, I think it's worked quite well. It helps it gives a standard to what we're doing, right? It
Absolutely.
allows
Yeah.
you to in the future check, like, are
Hmm.
we doing what we've said we would do?
Yeah.
And not why is that? We need to, improve our practice, or we need to change the policy.
Yeah.
Um, and it protects us in a way as well, right? If suddenly there's a new intensivist or a new leader somewhere who says, nope, this is not safe, I don't believe in this, it's going against a policy that's been written. So it gives you a level of protection as well.
Yeah. That's a good perspective as well. Okay. Evidence-informed practice, we've talked quite a bit about that. Everything that has been put into this and its development has been evidence-based, looking at different CPGs and ECMO mobility research. So I don't think there's any question there. We talked a lot about culture, specifically ICU culture, and then quality improvement and critical reflection. You talked about reactive development. Now that it has gone through, there seems to be multiple iterations that have occurred. Do you think that there
Mm.
is constant reflection on patient choice, team aspect, the debriefing, or are you kind of just in a routine now where you're just kind of steadily moving forward and incorporating maybe more procedures, as you said?
Yeah, I think we're pretty well established with what we have. Um, I'm not the primary person on this ECMO team anymore, so I'm kind of a secondary outside person who's keeping tabs on things and helping
Yeah.
make sure that some things are sustained. Um, but I think we have a pretty good routine. I think it's a matter of figuring out how do we make sure we're sustaining what we're doing. Um, and then adding components like verticalization.
Hmm.
And when we get a new piece of equipment, what do we need to do to really standardize this and make sure we're doing it in a safe way?
Yeah.
um yeah, and also because the number of patients kind of fluctuates,
Yeah.
that's a risk in a way as well, right? Like we need to find ways to make sure that the skills are fresh and that everybody's
Maintained.
standardizing what they're doing still.
Yeah.
Yeah.
If you're having one ECMO patient every few weeks or months, it's harder to keep that level of.
Yeah. Yeah.
Okay. Um, what advice do you have for hospitals that are starting out using this framework? How would you encourage them to utilize this?
Um, I would be thrilled if people download the paper and read it to start with.
I
And
love that.
then and then I don't know how it would look to use this as a tool.
Yeah.
Every time I've presented it at conferences, I've said, please use it and let me know how it
Yeah.
goes, right? Because I think it can evolve to be something even more useful. The framework has the tables that
Yep.
are associated with each element that are meant to give practical ways that you carry out these ideas. It's not it's not um, it's not totally inclusive of everything, of
Yeah.
course. So maybe there's things we've missed. It's also not meant to be a checklist. It's a list of things to consider, but it's not a checklist. It's not like these things are required. So
Yeah.
I would really welcome anybody to give feedback and say, maybe these elements came together very easily. These other elements we actually need more guidance on. I think it's also a reminder that the physical therapy team or the rehab department will not achieve all this in isolation.
Yes.
You need surgeons, your ICU intensivists, your perfusionists, your nurses, your RTs. You'll need quality improvement people. You'll
Yep.
need policy people. You'll need education people. So again, hopefully, maybe it can even be used to get stakeholders on board, right?
Hmm.
To say, actually, this is a recommended way to make this program work. We need you to contribute to these elements so that this can be a safe, comprehensive, effective program. Um, so I think it's probably trial and error for people right now, and
Yeah.
I'm sure it can be improved. I mean, it's meant to not be so specific to the task of mobility because again, we have a guideline for that,
Yeah.
but it's meant to give a framework on kind of a long-term development of a program. So I would love feedback on how it goes from people, and we could improve it. Again, maybe tweaks to the framework are needed, but more than that, tools to augment its uptake and facilitation. Maybe
Yeah.
there's some checklist that can be made. Maybe who knows what. Yeah, I mean, I'm not an expert on quality or frameworks or care delivery,
Yeah.
and I'm sure other people have a lot that they could bring to the table to make this even more effective.
I do think it has a lot of flexibility built within it, which is really nice for multiple, different types of institution, different sized institutions to be able to utilize it. I also think that it can really just give that roadmap of who needs to be involved and maybe how we get them involved. And I really like, as we talked earlier, that the patient is actually a part of this.
Mhm.
They're
Yeah.
they're they're a part of the decision making. They're a part of, the whole piece as they are the center of that care. Um,
Yeah.
you talked about what this article is, and you talked about what it's not, and we've talked about how it might be utilized. Is there anything else in the framework that maybe we didn't hone in on or that you wanted to add any added piece to?
We didn't touch too much on what we call the enabling
Oh yeah, the
factor.
enablers.
Yeah, but that's
Let me see if
it's
I had
simple.
a, yeah.
But yeah, this is about looking at increasing the frequency of mobility and rehab interventions. And again, that's figuring out how to use your nurses when your therapists aren't there. What does the OT do if they're there? What does the PT do? And similar to that, um, some consensus on your team as to the scopes of people,
Yeah,
right? Like we need to get the nurses involved. There's no reason they can't take a TheraBand and take a patient through an exercise program that you've prescribed for them. There's no reason they can't mobilize patients by standing and walking to a chair. Our nurses use a bike with the patients a lot in the bed,
nice.
with the right training and these things going on. So that's a big element, is working on scopes of practice and people creating a culture and an environment where people feel safe and capable to expand a little bit.
Yeah,
And then the third one is having the appropriate mobility equipment. I mean, I do very much believe that an effective physical therapist can do most of what they need by
with
themselves and
minimal stuff. Yeah,
other people around. But there are certain situations, populations, and patients with certain limitations that absolutely need higher level equipment and sometimes costly equipment. So
yeah.
that is a big consideration as well. Um,
Any pieces of equipment that you find that you use more in those more critical situations, maybe when you're not ambulating or on the days that you're trying to work on other impairments?
Yeah. So one that I think has been absolutely critical for a number of our patients is, and I won't say the brand name, but essentially a tilt table with a leg press, a body weight leg press,
Okay.
right?
Yeah.
This is incredibly important for patients who are having difficulty bridging that gap where they have active strength, range of motion, maybe partial anti-gravity, lower limb strength,
Hmm.
but not sufficient to do that sit to stand
Yep.
or to walk. So it's really, really important for those patients. There's even patients who are very, 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 very weak that you can get on there with a low incline, even 10%, and they're at least activating. And the key
Yeah.
is repetition. The key is that you're making the difficulty level, exactly what they need. And that's very hard to do in a supine position or a sitting position
Yeah.
without
It's all or
any,
none in those type of,
yeah. So it's been very helpful for those patients. It's also been really helpful for those patients who, as we discussed before, they may actually be walking every day,
hmm.
but once you're in an upright position and you're moving forward, you can walk without having even anything close to normal
Hmm.
strength, right?
Yeah.
So you can really go back and target muscles to strengthen them. You can put them at a higher incline and do 10, 15, 20. I mean, we've done like 140 repetitions in one session with some patients.
Yeah.
Um, so again, I think the ICU therapist is often focused on mobilizing, and that's absolutely, in most cases, a priority.
Yeah.
But keeping in mind your principles of exercise and exercise physiology and what it takes to strengthen and returning to some of those basics
Yeah.
um, is really necessary. And some of these exercise equipment will help us to do that.
And I think starting early on really does give them a step forward later, where that profound ICU weakness kind of lingers. If you're starting earlier, maybe you get a little bit of that rebound faster and also get them to coordinate and do activity when maybe PT or nursing isn't available. Like they get to the point they can use that TheraBand on their own or just
Yeah,
have the ergometer placed for them
right.
if hemodynamically stable and, fill in the
Yeah,
blank on that. Okay.
yeah.
Anything else about the key enablers? I think I think we hit them kind of haphazardly, but you did a nice job just now breaking it down nicely. Um, Before we kind of sign off, you talked about ELSO CPG came out in January 2025. Any other resources or courses if you want to promote
Um,
resources in that sort of way?
yeah, I mean, I, especially in my region, I haven't been able to do anything specific to physical therapy or rehab on ECMO. But what I found is that actually forced me to just be attending the medical side of things,
Yeah.
which of course has great advantages, um, but also has the limitation that you're not learning very specific things related to rehab. I would say that in this setting, say ECMO and physical therapy, you can do really well by taking evidence to know what steps to take, how to screen patients, how to
Mhm.
move forward with patients. And you can pair that with your attendance and involvement in these multidisciplinary and medically driven conferences, um, and bring them together to create that learning,
Yeah.
to fill that learning need. Um, I know there are conferences and or sorry, not conferences. There are some courses in the US. I just haven't done them and I can't say anything about them,
Yeah.
but I would love to be able to take part in them at some point. But it's really a field where you have to piece together your resources. You do have to be proactive. You have to drive your learning
Yeah.
because nobody's, although it is a big emphasis, as you have said, like a
Yeah.
CSM like that. Um, you can gather a good amount. Um, and just maybe to to go back to that for a moment as well, like that's also part of why this framework came to be, because I feel like I've become the spokesperson for physical therapy and critical care in this country and the Middle East
Yeah.
generally. I mean, there's a lot of people out there doing really good things, but I've been lucky to be exposed to a lot of these as well. And I felt like I was being asked for like the fifth time to talk about physical therapy on ECMO. And I was like, I'm just gonna say the same stuff. I'm just gonna say this is how you screen, this is how you progress, and I was like, there must be something more. I was like, that, and I think I realized that that doesn't tell you how to build your program. That just
Yeah.
takes how to take care of the patient in front of you,
Yeah.
which doesn't speak to sustainability and program development and all these other things.
Right.
So I remember being on a run one morning and I was like, I don't want to give the same lecture that I, there's got to be
That's fair.
something more meaningful. And then I was like, yeah, we don't have a way of doing this from
Yeah.
a program
Ground
perspective.
up.
And that's how it all happens.
I was
So
actually going to ask that question. Like, at what point did you working in this and doing this finally come to the point where you're like, we need to write this down. We need to promote
yeah,
this as a structure. And so it was
yeah.
on a morning run.
So yeah, yeah. I mean, typical answer, right?
I mean, the other part is important, right? Like, what do you do from the PT perspective? I think there is so much value in that. But you're
Yeah.
right. The sustainability part of it, the teamwork
Mm,
part of it, the how do I
yeah.
even start this thing?
Yeah. Yeah. I hope I haven't downplayed in any way, like the
No, I
need.
don't think you have.
And I was for a few hours or a day or two, I was actually like um worried when I didn't even know the ELSO guideline was being made. That's my own
Yeah.
oblivious, self, I suppose. And I was like, oh no, they've done it and now we can't do it. And then the
Yeah.
more I thought about it, like, no, these are different things. The ELSO guidelines is extremely well written. Kudos to
Yeah.
all those people who made it happen. It is an amazing resource. It ends on aspects of what are your outcome measures, what's the education you need, what are the things you need to monitor over time.
Yeah.
And I think that's where then the framework picks up.
Yeah.
And I've said this before as well, like the CPG, just like any clinical practice guideline, probably will benefit from a revision every five
Yeah.
years right,
Mhm.
is standard to incorporate new evidence. I hope that the framework is big enough that, okay, although modifications can be made, and I would welcome that, it's a more sustained piece of literature, hopefully, that will stand the test of time because it doesn't get to the nitty-gritty
Yeah.
of the procedure itself.
I think that's a good
So,
perspective. I think they really do go nicely hand in hand and complement
yeah,
each other. You did say
yeah,
something that is just, just interesting being human, right? Like, oh, they did it, now I can't do it, right? It is
yeah.
a very common thing in creating CEUs or lectures or, business or whatever.
Mm,
And I do think that different perspectives hold different weight and also different value. And so I do think this holds a great amount of value. And I think it's going to go a long way and hopefully become a really big part of, project development because that's really kind of it gives us structure and framework and bones
mm,
to that thing. Tell us
yeah.
how we can download this. You tell me how we can get everyone to read this article. We're gonna get views on this thing.
So it's available on PubMed. It is
PubMed.
an index journal on PubMed. I would imagine most of the other major indexes as well. You can reach me by
Okay.
email, by
Okay.
LinkedIn, by Instagram, and I
We'll
will
add it
send
in
you
the
the.
show notes.
Thank you. Um, and yeah, I think uh, just contact me if you can't get it in any other way. Download it and give it a read, and get in touch with me. Yeah,
And Aaron wants
and
feedback.
I want feedback. Promote it, reference
Use
it
it,
appropriately, use it. Give
a-
me feedback.
ask
I would
questions.
questions, comments, all of it.
Good, good. All right. Well, this was amazing, Aaron. I think that this is going to be profound on its own. I won't make you give profound, lasting words today unless you're ready for them.
Yeah, that's fine. Thanks.
Give it a read. We'll have Aaron's information in the show notes. Download it, read it, use it, and get after it. I hope you all have a wonderful day. And I'm going to say it again, whatever you have to do, get after it.
Thank you, Rachel.
You are very welcome, Aaron.